Today I am Dr. Dilip. Today our topic of presentation is small intestinal tumors. So these small intestinal tumors are rare, comprises only 10% of the whole gut tumors. The 90% tumors are the large gut tumors they are originating from the stomach. So some overview of the small intestine. The small intestine is one of the most important organs for immune defense, and it is the largest endocrine organ of the body, which starts from the pylorus and ends at the cecum, having three parts: duodenum, jejunum, and the ileum. Totally, the length is comprises about 300 centimeters. Has placa circularis. These are the mucosal folds which increase the surface area of the mucosa for the absorption of the gut contents. The duodenum is the retroperitoneal organ, and which is supplied by the celiac artery, branch of the celiac artery, as well as the branch of the superior mesenteric artery. The jejunum and ileum are supplied by only the branches of the superior mesenteric artery. The jejunum occupies the upper left abdomen, and the ileum occupies the lower right part of the abdomen. The jejunum has thick vault and wider lumen than the ileum, and mesentery has less fat and forms only 1 to 2 arcades. The ileum contains the Peyer's patches. In the ileum and jejunum are supplied by the superior mesenteric artery. There are several functions of the small intestine. One of the most important is the digestion and absorption of the nutrients, and the second one is the main endocrine, having a main endocrine function. It secretes several hormones for the functional for the absorption as well as the defensive mechanism of the gut. There are several hormones like secretin, cholecystokinin, gastric inhibitory peptides. So just like the cholecystokinin, when it releases, when the fat comes into the contact in the duodenum, the gallbladder, it contracts the gallbladder, and when after the contraction, the bile releases into the gut and metabolism starts. So there are several hormones like this. They increase the endocrine functions of the gut. For the immune function, the gut mucosa having IgA, which having its immune defense mechanism, and which decreases or prevents the translocation of the bacterial from the gut and prevents the sepsis. There is a Peyer's patches, which is the main defense mechanism of the gut, which prevents the translocation or transmigration of the bacteria, viruses, and it prevents it is the main gateway of the human body. The neoplasm of the small gut are rare. They comprises only 10% of the gastrointestinal tract. The 90% are originating from the large gut or the stomach. The majority of the small bowel neoplasms are benign, comprising adenomas, lipomas, hemangiomas, and neuroendocrine tumors. They are frequently asymptomatic and identified incidentally, but can present with intussusception, small bowel obstruction, and bleeding. Due to the rare, there are several protective mechanisms of the small gut which prevents the production of the neoplasm in the small gut. They are the protective mechanisms are the first one is the rapid transit time, which due to the rapid transit time there is less contact of the carcinogenic agents to the gut mucosa. And the second one is the local immune system of the small bowel mucosa having IgA, which prevents contact to the mucosa. And third one is the alkaline pH of the small intestine. It prevents the overproduction or the production of the bacteria, viruses into the gut, and relatively low concentration of the bacteria and low concentration of the carcinogenic products of the bacterial metabolism. There are several mucosal enzymes which destroys the certain carcinogens, and the most efficient epithelial cellular apoptic mechanism that serves to eliminate clones which harboring the genetic mutations. There are several risk factors which produce the neoplasia. These are eating the red meat or ingestion of the smoked or cured food. These are the most common carcinogenic factors. There are several diseases like the Crohn's disease, celiac disease, hereditary non-polyposis colorectal cancer, familial adenomatous polyposis, and Pearce-Trigger syndrome. These are the diseases which are prone for the development of the neoplasia. Mostly the neoplasm of the small intestine are asymptomatic, but they present incidentally. There are several when they present with symptoms like the vague abdominal pain, bleeding, obstruction. So we have to think of these small intestinal tumors. The most common mode of presentation is crampy abdominal pain, distension, nausea, vomiting, hemorrhage. There are several diagnostic tools to diagnose these small intestinal tumors. One is the radiological examination, small bowel enema, which is called the enteroclysis, and the small bowel intestinal small bowel follow through, CT scan, and angiography when there is a bleeding. But in spite of all these investigations, the small bowel tumors may be missed. So keeping in mind if the tumors are in the duodenum, so the upper GI endoscopy can diagnose. By the help of upper GI endoscopy, we can diagnose the polyps or the duodenal growths or the neoplasia. Or if the tumor or neoplasium is at the terminal ileum, by doing the colonoscopy we can diagnose the terminal ileal neoplasms. There are several tumor markers like the 5-hydroxy indole acid for the carcinoid, which is a malignant tumor of the small gut, and the second tumor marker is the CEA of the associated with the small bowel adenocarcinoma, but the level will be raised only when there is a liver metastasis. Otherwise, the CEA level in the small intestinal adenocarcinoma will be not raised. There are benign tumors are the adenomas or the leiomyomas and the lipomas and the Peutz-Jeghers syndrome. So the adenomas are associated with the bleeding and obstruction usually seen in the ileum, but the majority of the adenomas are asymptomatic. They may be true adenomas or villus adenomas or the Brunner gland adenomas. Second is the leiomyoma, which is now in the group like GIST, gastrointestinal stromal tumors. Leiomyoma and malignant variety is the leiomyosarcoma. In the past, this was the name is the leiomyoma, which is most common symptomatic benign lesion, and it is associated with the bleeding. When it is associated with the bleeding, the diagnosis is confirmed by the angiography, and it is mostly located in the jejunum. The leiomyomas growth pattern is, if they are in the gut lumen, means intramurally, they cause obstruction, but if it is intramural and extramural, that is called the dumbbell, so it can cause twist or the torsion of the gut, so it can present in as a intestinal obstruction. Third is the lipoma, which is most common in the ileum, causes obstruction, and the main source of intussusception, which is leading point in the intussusception. If there is a ulcer in the lipoma, it can bleed, but there is no malignant change or malignant degeneration. There is one most common syndrome which is called the Peutz-Jeghers syndrome, which is inherited syndrome. It presents as mucocutaneous melanotic pigmentation like on the face, buccal mucosa, palm, sole, perianal areas, and having gastrointestinal polyps. Polyps mostly involve the jejunum and ileum, followed by, but the common areas are the colon, rectum, and the stomach. This is the picture of showing the small bowel enema, which is showing the filling defect, which is the common presentation of the polyps. Symptoms are the colicky abdominal pain, which pain may be intermittent or it present as intussusception, or when there is a ulcer, it can present as bleeding. Treatment is surgical resection of the bowel causing obstruction or bleeding, but the cure is impossible in the Peutz-Jeghers syndrome, because if it is involving whole of the small gut or the duodenum or in the colon, so it is impossible to resect whole of the gut, small gut or the large gut. There are several malignant tumors of the small gut, mostly the adenocarcinoma, which arises from the epithelial cells, and its frequency is about 35 to 50%, and it mostly involves the duodenum. And the second one is the carcinoid tumor. It originates from the enterochromaffin cells and comprises 20 to 40%, and mostly involve the ileum or the appendix. The third one is the lymphoma. lymphoma may be primary and secondary and accounts for 10 to 15% and involve the ileum. And the fourth one is the gastrointestinal stromal tumors, comprises 10 to 15%. And the fifth one is the metastatic tumors, which involve the small gut. The primary tumor may be melanoma, and the ovaries or the uterus and the colon, they can involve the small gut. Adenocarcinoma is the most common carcinoma of the small bowel, most common in the duodenum and the proximal jejunum. Half involve the ampulla of the Vater. Carcinoid is the tumor originating from the enterochromaffin cells and arise from the foregut, midgut and hindgut. And the most commonest site is the appendix. The second one is the ileum, and the third one is the rectum. But when the tumor is in the small gut, it is more aggressive. If it is in the appendix, there is a 3% chances of metastasis, but when it is in the ileum, there is a 35% chances of metastasis. And when it is in the appendix, it is solitary lesion, but when it is in the ileum, having multiple sites, more than 30% having multiple sites, and mostly the 25 to 50% of the carcinoid tumor with present as liver metastasis. When there is a liver metastasis, so the carcinoid tumor can present as carcinoid syndrome. Mostly if the tumor is confined to the small gut or the appendix, it is not metastasized to the liver, it can't present as carcinoid syndrome. But when it involves the liver, it can present as diarrhea, flushing, hypotension, tachycardia, fibrosis of the endocardium and valves of the right heart due to the production of the serotonin, bradykinin and substance P. The fourth one is the lymphomas. Most common intestinal neoplasm in children less than under 10 years of age, but in adults it comprises 10 to 15%. And the lymphomas may present as intestinal perforation or intestinal obstruction. So there are two types of the lymphomas which involve the small gut. One is the primary lymphoma, which is originating from the small gut, like the main source or the main focus is at the Peyer's patches, but it present as a secondary lymphomas when the primary is systemic origin, like the blood cancers. So it can involve the small intestine. So the criteria for the primary lymphoma of the small bowel, when there is absence of the peripheral lymphadenopathy, normal chest X-ray without evidence of mediastinal lymph node enlargement, normal WBC count and differential, and at operation the bowel lesion must predominate and the only nodes are associated with the bowel lesion, and absence of the disease in the liver and the spleen. The treatment for the benign lesions, all symptomatic benign lesions or the tumors should be surgically resected or removed endoscopically if they are smaller in size by doing upper GI endoscopy and colonoscopy. The duodenal tumors, if they are smaller size like 1 centimeter, endoscopic polypectomy can be done, but if the tumors are larger or more than 2 centimeter, they are resected surgically, like the Whipple procedure is done. And the other malignant lesions like the adenocarcinoma and the wide local X resection if the tumor is smaller one, but if the larger tumors, it can be resected with 10 centimeter proximal and 10 centimeter distal margins with mesentery. In adenocarcinoma, chemotherapy having no proven efficacy, and small bowel lymphomas, if they are limited or localized to the small intestine, that part should be resected and along with the adjacent mesentery. But if it is diffusely enlarged involvement of the small gut, there is role of chemotherapy rather than the surgery. So the primary therapy is chemotherapy. The treatment of carcinoids is segmental intestinal resection and regional lymphadenectomy. If the tumor is less than 1 centimeter, has lymph node metastasis, or more than 3 centimeter size, so there are more chances of lymph node metastasis, like 75 to 90% the lymph node will be metastasis. So there are chances of, in the ileum there are chances of multiple origins. So during operation or during surgery, entire small gut should be examined. If there is metastatic lesions, debulking associated with long-term survival and the symptomatic treatment of the carcinoid syndrome is done with chemotherapy, which gives the 30 to 50% response, like the doxorubicin, 5-fluorouracil and streptozocin, and octreotide is a symptomatic relief in carcinoid syndrome. There is other tumor, gastrointestinal stromal tumors. They are most common mesenchymal tumors arising in the small bowel, but the 70% are originating or arising in the stomach. Only the 15% malignancies are the small bowel. And in the past, the leiomyomas and leiomyosarcomas and smooth muscle tumors of the small bowel are now considered as in the GIST. Mostly they present as bleeding, and the tumor marker is CD117. The treatment of the small intestinal GISTs is the segmental resection. If it was preoperatively diagnosed, lymphadenectomy should not be done, and if there is a associated lymph node metastasis, there is a role of a drug which is called the imatinib, which is used and having efficacy, and which 50 to 60% shows evidence of reduction in the tumor volume, which is they are using as a neoadjuvant and adjuvant treatment under investigations. The last one is the metastatic cancers. One of the tumor is the melanoma, which involves the small gut, and ovaries, uterus, they can involve. So the treatment of the metastatic tumors involving the small gut is the treatment of the primary disease. Thank you so much.